the healthcare literature, the problems of healthcare innovation are described in terms of a translation gap. And to some extent, Anne was talking about this translation gap as well. So the idea is that there are two basic translation gaps in healthcare, sometimes referred to as the first and the second health translation gap. So the first health translation gap is about how we move from science, so we get breakthroughs, whether it's in genetics or any other kind of area of biology, chemistry, and how does that then get moved into the development of new drugs and new therapeutics. And as we know, the time it takes for that process is extremely long and extremely expensive. So that's referred to the first translation gap, the movement from science into, if you like, actual medicines that are used to treat patients. And the second translation gap is where you have new innovations, whether it's new medicines, new ways of treating populations, new clinical care pathways that we know are more efficient and effective, but actually getting those to diffuse across a healthcare system. And we were talking before the break about Canada. Things happen in some provinces that seem to work very well, but we don't do necessarily a very good job of diffusing those across to other provinces. So that's sometimes referred to as the second knowledge translation gap, moving what we know into practice more broadly. So sometimes also referred to as the knowing-doing gap. Now, while I think that that's quite a useful way of thinking about knowledge or the problems of healthcare innovation, I think that just focusing on knowledge translation actually underpins, limits our understanding of healthcare innovation. Because I think in healthcare, it's not just about building bridges. All right. Yes, we need to build bridges between organisations and between professions, but actually, as fundamental are pulling down the barricades that exist, that are built around professional norms, institutionalised practices, regulatory regimes, that actually mean you can have the bridges. I'm not going to try and do it now, but there's a wonderful picture on Flickr there, which I had, which gives you a lovely bridge with barricades at each end. And I think, especially in the UK, governments have spent a lot of time and energy, and I'm going to talk about a particular initiative later, at building bridges between groups, between organisations, but they haven't necessarily incentivised the organisations and the professions to actually change their practices. So I think healthcare innovation is about translating knowledge, but also transforming practices. And sometimes we spend too much time and energy on the translational idea and not enough on actually thinking about how we can transform our practices. I think the other thing about the problem of treating these knowledge translation gaps as two independent gaps is that it presents a very linear view of the innovation process. So it assumes you start innovation at the research lab, you develop your new science, and then that moves into pharmaceutical companies who develop the new therapeutic, and then that moves into the clinic, into the hospital or the healthcare setting. Actually, I think successful innovation brings those three communities together in a much more interactive way so that they transform practices as they go along, rather than assuming that once you've got a new therapeutic, people will automatically start using it and transforming their practice. So that's really what I want to talk about, and I want to start with a couple of examples that we've had from our own research projects. First is a very simple example that was we were looking at in a particular region of the UK. Now, I don't know what it's like in Canada, but in the UK, and this still happens in many, many contexts, if you need new cataracts, you don't realise you need new cataracts until you go to your optician to get new glasses, and your optician says to you, no, you don't need new glasses, you need new lenses. It's an operation that's going to be involved here. So what normally will happen is you go to the optician diagnoses you, but they're not allowed to diagnose you, so they send you to your GP. Your GP looks in your eyes with their very little technology and says, I don't know, but if your optician said that, that's probably true. So they then refer you to the consultant, and you're now not on the waiting list. your figures about waiting list statistics. You're not on the waiting list because your diagnosis hasn't been confirmed, but you're kind of on a pre-waiting list. So you wait around for about 3 or 4 months. You finally get to see the consultant who says, yep, you need cataracts, and then books you into an appointment, which is often kind of 6 months in the future because they have to see so many. Before you go for your operation, you have to go back to your GP, not to see your GP, but to see your nurse to make sure, and she will give you a kind of health check to make sure you're fit enough to have the operation. Once she's agreed that, you can then go and have the operation. Once you've had the operation, you go back to the consultant after a couple of weeks to make sure the operation was successful. And then finally, and it takes between 9 and 12 months traditionally, you go back to your optician to get those glasses that you thought you needed 12 months before. All right, so it's a very long, drawn-out process. So in this particular region, they recognized that this wasn't surely the most efficient way to do it. So what they did was they brought together all the various parties that were involved, both organizationally and professionally. So they brought the opticians together with the consultant ophthalmologists, together with the GPs in that area and the nurses. And they had representatives of all those groups involved who, it took about 9 months to thrash out a new process. But what they do in this one region in the UK is now you go to your optician can diagnose you formally, put you on the waiting list, you go and have your operation. You don't even have to go to the nurse for your checkup because you do a telephone interview, which is a self-check. And then you go and have your operation. You don't go back to the consultant after you've had your operation. You go directly back to the optician who both diagnoses you and now also makes sure that the treatment was successful, and then you can have your new glasses. So it went from a 12-month to a 6-week process. Everybody was very happy with it. Now, in a sense, that's a successful innovation, but I think it picks up on some things that were being talked about before. What they then tried to do was diffuse this to other health authorities because it seemed, good practice, best practice even, or I don't like best practice, but good practice, let's call it good practice. But it was totally unsuccessful there. And what happened was when the various people started talking about it, the consultants in these other regions, the ophthalmologists, would say, no, that's never going to work. And the main reason they said that was they said opticians can't diagnose. Now, I think if we can talk about this in a number of ways, and a lot of people say, oh, it's just the not invented here syndrome. I don't believe it's the not invented here syndrome. I genuinely believe the consultants in the other regions didn't appreciate what the knowledge and skills and abilities of the opticians were. And so it was only through this getting together and talking and challenging each other that they were able to come up with a process whereby the consultants did some extra training of the opticians locally, so they had them for some sessions. They also created very good networks between the consultants and the opticians. So the opticians knew that they could go and talk to the consultants if they had a query, if they weren't certain about anything. And so it was on that basis that they were able to move forward with this changed process. What we've argued is that what you need to do, therefore, is not transfer this new best practice, but more transfer the process whereby you will get these people locally to come up with their own type of change. So it's not transferring the knowledge of this is what you do, the practice, but knowledge of the process, because you're going to have to go through this process. Maybe you can circumvent it a bit, make it slightly shorter, but you're still going to have to get others to recognize that they all need to transform their practice if they're going to change how, in this case, to treat cataracts. That's one example. Second example is something I'm working on right now, and we've talked quite a lot already about health records and how health records have the potential to improve collaboration across different groups, different specialists, different organizations. Anne was talking about the US. The US actually is not that well developed in terms of its health record systems. But we were doing some research in a local to us, a Boston network, where they do have a fairly well-developed health record system. It was a self-grown system originally, and the whole point about health record systems, at least if they're not just, printing rather than handwriting your prescription, is that they link across organisations, whether it's to your pharmacy or from your primary care to your hospital. And that interoperability is based on the idea that you have checkboxes, you have menu-driven diagnosis, treatment, symptom lists, and so on. Now, remember, that's very different to how doctors have traditionally made patient records. So traditionally, doctors made patient records, well, we all remember them, well, any of us that are, over 20, with, they had a piece of paper and they wrote something on it and then they put it into a folder, and the next time you came, they got that out to see. So it was basically a narrative, usually a very short narrative, which was primarily for themselves, so that next time you went to see them, they would, be able to see, well, what have you been treated with in the past? Now, when you start talking about medical records that are going to be interoperable, you've got a very different game, because it's not for the doctor, it's now for very diverse partners, including the patient, because the whole thing is tied up sometimes in health literacy, that are going to be making use of this record. Now, to cut a long story short, there's a lot about this here, but one of the things that we've observed in this record system, which in many counts is very successful, is that doctors still like to use the narrative. All right, they have to check the box. Well, they don't all check the boxes. That's a problem. So they don't all check, especially the specialists. The specialists are very bad at checking the boxes. The primary care physicians much better at checking the boxes. Often the specialists assume the primary care people will check the boxes for them when they send them their narrative, but that doesn't always happen. So for many records, there is a distinction between the check boxes, what it says in your top-level diagnosis and treatment and so on, and if you read the narrative, there are often many other things that you've got or had that aren't in the check boxes. So that becomes a problem, and it becomes a particular problem because with health records, electronic, what doctors have learnt to do very cleverly, I guess, is to take their old narrative genre and actually develop it, because now they've got all these wonderful tools like cutting and pasting and writing templates that they can just stick into the records. So the narrative part now becomes not the short handwritten note that filled into to the top of your little file, but this great big long pages and pages of narrative that they use, partly because they can, I think that's part of it, but also because now you've got the health record being used by so many different constituencies that they're trying to make accommodation for everybody. So I think this whole notion of health records are going to make us more efficient, we need to think about, well, okay, but there are some downsides in it that we need to understand in terms of how people actually use it in practice. So I guess these two examples are just examples of how, yeah, if you look on the surface, you could say in both of these cases, there was a successful innovation. One was to develop their own healthcare medical record system, the other this very new way of treating and diagnosing cataracts. But in both cases, one, it didn't translate or transfer across more broadly, and in the other, there was significant problems in terms of using the health record to really build the kind of collaboration for a number of different reasons. So what we're looking at then is innovation as a process of change that depends both on, as I say, the translation of knowledge and the transformation of practices. So what kinds of capabilities might be pertinent to thinking about how we translate knowledge and transform practices? Well, we're using actually a model that wasn't developed by ourselves, but was developed by some colleagues at I don't even know where Owen Smith and colleagues are. But anyway, Owen Smith and colleagues, that's bad, isn't it? Who taught any of you students, all right, that's not a good thing to do, all right? Anyway, they talked about two types of capabilities that they call relational capabilities and integrative capabilities. So relational capabilities are the ability to work across organizations. So to build those bridges that link hospitals and primary care practices, social services, maybe even schools and hospitals, depending on what the particular needs of a patient or a type of problem. And then integrative capabilities are the ability to move back and forward between different practices, in particular between science and clinical practice, but it could be between different types of clinical practice as well. So it's those capabilities to be able to look at practice in a more holistic way and understand how different parties will need to be able to change their practice to encourage innovation of some form. So we're applying that framework. So the examples I gave you before were various projects that we've worked on, but the group at ICON are now working on a major project which is involving, some of you might have heard of them, clerks. So in the UK, we talked earlier about innovation zones. In the UK, they've taken that idea, the government has taken that idea and tried to implement it in practice. So clerks are, I will turn to the next one because I've written it down there and it's a bit of a mouthful, collaborations for leadership in applied health research and care. So the UK government set up 9 regional clerks in late 2009, early 2010. So the whole idea of these clerks was to focus on that third bullet point, focus on developing innovative models for conducting applied health research and implementing the findings to improve outcomes. So it's very much the kind of idea that these clerks were given a bunch of money, and the money wasn't tied, as it often is, as we know, for research purposes, to particular projects that you'd already pre-specified. Rather, it was tied to a general bid to say, we're going to try out various ways to make innovation happen in our healthcare area and see what happens. So 9 of these clerks were funded. They had significant funding. So there was 5 million for 5 years. And we're at the point now where they're having to rebid to see if they're going to get an extended period. We don't know what the outcome of that will be, which is why some of the data I'm presenting is quite sensitive, and I'm not going to talk about individual clerks for that reason. But they not only had those 9 clerks that they funded, they also funded 4 evaluation projects. So 4 projects whose remit was to evaluate what was going on in these various clerks to see what we could learn from that could be shared both nationally and internationally. And we are one of the 4 evaluation projects that are looking at, we're actually looking at 3 of the clerks, and we also have an international arm to the research. We're looking also at initiatives in Canada and the UK. Because in fact, in the white paper that initially proposed the clerks, it was said that it was based on ideas from Canada, which is an interesting thing. I was talking to someone earlier, I think it must have been a little pilot project in Canada that never actually magnified, whereas in the UK they thought it had, so they started from the magnified process. Anyway, we're using a variety of different methods, and I'm not going to go through too much of this because I just want to come out with some kind of general conclusions about what we're seeing from these. So they were funded for 5 years. They all were thematically organised. So while there wasn't projects they had to specify in their proposal, they had to say what thematic areas they were going to concentrate on. So a lot of those were common across clerks. So a lot of them had a stroke theme, a lot of them had a diabetes theme, a lot of them had a mental health theme, a number of them had children's care needs and so on. So they had these various themes, and then they all have a director, a strategic board, and various kinds of governance structures that they have to have. But aside from that, there are significant differences between them. Now, again, I can't go into too much detail about them, but for one thing, they have very different directors. So in the 3 clerks that we're looking at, one of the directors is a social sciences academic, one of them is an academic medical faculty member, and the other is a nurse practitioner who became an administrator and now is director of one of the clerks. Very different kinds of background, therefore. That links to their very different focuses that I'll come on to in a minute. Also differences, some of the directors have actually changed over the period that they've been in place for. But they also differ in terms of how much centralised control that director has. So in one of the clerks we're looking at, the director wants to know everything that's happening and indeed wants to kind of almost control it. So they chose the theme leaders very carefully based on, you know, what they thought they wanted to do here. They have to agree all the projects within each theme. In other cases, the director has very limited involvement in day-to-day and leaves the themes to get on and organise and conduct projects as they see fit. Also differences in terms of the distribution of the budget. In some of the clerks, they distributed the budget from the get-go to all of the various themes and projects within that. In other cases, they kept a significant portion of the budget for kind of central administration. So how are we going to make sure that these themes are all coordinated? We need some budget to be able to do that, to think about coordination across. They also have very different interpretation of the initiative. So even though, you know, go back to this slide, the focus on developing innovative models for conducting applied health research, that was in the proposal that they had, or the bid that they had to respond to. But for some of the directors and the clerks, therefore, that translates into getting as many academic publications out as possible. For others, it translates into, let's really do something at the local level to change practice in a particular area of health. And for others, it translates into, let's try and build a capability to be innovative moving forward. So they're very different in terms of how they're interpreting the initiative. And that relates to, as I say, the implementation orientation, where some of them are, you know, how they're measuring themselves is quite diverse, changing practice versus publications, for example. There are also differences in terms of how much I'm sure you're all familiar with this, a call for proposals comes out, you've got some research already ongoing, you want to now badge it as part of the initiative. So it's really kind of using funding for, you know, doing what you're already doing, but now you're getting a bit more funding for doing it, versus other clerks which really saw this as an opportunity to say, okay, let's really start something new and see what we can do by reorganising and bringing together groups of people that haven't previously worked together. And lastly, they also differ in terms of how the mechanisms that they're using to try and encourage networking, both across the clerk, the single clerk, across the 9 clerks, and then across the healthcare community more generally. So just as an example, one of the clerks has appointed what they call diffusion fellows, and they've spent a significant amount of their budget on these diffusion fellows. These diffusion fellows work part-time in the clerk. Their other job is kind of continuing with clinical practice. Some of them are nurses, some of them are administrators in healthcare organisations and so on. But half their time is spent as diffusion fellows, where the idea is for them to find out what's happening in the projects and then diffuse it to the broader community. Now, does it make a difference? Well, one of the things we're doing is we're conducting social network analysis. So we're asking people to say, who do you go to for information that you need to conduct your work within the context of this clerk? I mean, we ask a lot of different questions, but they're all about who you contact to carry out your clerk-related work. And what we've got here is the 3 different clerks in terms of how often one person not just said, I go to Anne, but Anne also then would say, I come to Sue. All right, so that would be a reciprocal tie. A one-way tie is where I say I go to Anne, but she says she doesn't come to me. All right. Now, reciprocal ties from a kind of knowledge translation and transformation are very important, because reciprocal ties mean that there's some kind of relationship there, there's a trust there, there's some kind of equal idea of equal sharing. It's not just I go to you and give you information, or you come to me and ask me for information, but we're giving and sharing continuously. And those kinds of reciprocal ties are much more likely to be sustainable in the longer term. So what you can see here is out of the 3 different clerks we're looking at, and obviously the one has got 30% of all the ties that were talked about were reciprocal ties. Now that's a significant amount in any network to have that level of reciprocal tie. Remember, clerks are very big organisations. There was 120 participants in between 120 and 180, depending on the clerk, in the survey that we conducted. So to have 30% reciprocal ties suggests there's quite a lot going on there in terms of real fundamental relationship building versus one of the others where there's only 16%. So I think the way in which these things are being managed and organised does make a difference in terms of how these relationships are actually building. We're also, I'm not going to go through this, I don't think, because of time. We're also doing a cognitive mapping exercise where we're looking at what people say are the things that are driving the success of their innovation, the success of their projects that they're engaged in. And we're going to be able to use this then to compare clerks to see what things they think are driving the initiative. And just to give one example, so this is the Canadian example, where they think that kind of conducting research that is focused on patient needs is the most fundamental thing to being successful in terms of our elements at the end, so building capability, improving equality of healthcare delivery, improving inefficiency, and so on. I'm pretty sure that we're not going to get this in all clerks, that notion that you have to focus on patient needs. Anyway, we're doing that. But let me come to kind of what the conclusions from some of this. What we see then in the 3 clerks, if I just focus on that, in terms of the bridging activities that they're engaged in, we have some that are really bridging very specifically to engage in the project which they're doing. So I need to have a paediatrician on my project because that's what I'm trying to do. So I'm going to find the paediatrician who I want to work with, and that's it. Other clerks are much more about, okay, we need to build networks not just to carry out the work that we're doing, but more generally to bring people in, to engage the populations in the whole process of research that we're engaged in. I'm not going to go through perhaps some of the reasons why because of time. Then in terms of that integrative capability, the removing barricades element, we do see in a number of the different projects that there were practice differences that created the problems that it was very difficult to actually innovate because doctors wouldn't let nurses diagnose or whatever else, the things that we're all very familiar with. And whether those kinds of practice divisions were beginning, because we're at quite early stages now, but we saw beginnings of glimpses that there was opportunities to remove some of these barricades around practice, I think really depended on how the clerks were envisioned and led. So you could characterize our 3 clerks as one was an academic clerk, one was a clinical clerk, it was good in terms of what it was doing, but it wasn't really going to likely transform beyond the immediate local changes that were being implemented. And there was just the one where we could say there was a real academic clinical partnership in the sense that the academics respected the clinicians and the clinicians respected and listened to and tried to engage in the kind of activity going back to the Cataract project where you really did, a simple practice, but you transformed the way people were involved in delivering the healthcare. So, relational capabilities can either be based on using networks, so building single temporary bridges. I hate to use too many metaphors, but I think metaphors help us to understand, versus building networks which are about permanent bridges that you're trying to build across these very diverse communities. And integrative capabilities are built either by skirting the barricades, all right? You lead from the academic, so you really just ignore the clinician, or you lead from the clinician and kind of largely ignore the academic, or you really try to remove the barricade by genuine co-production, working really in a very collaborative way. So just to finish off, that's the kind of model that we're trying to think of now, where we have got these differences across our clerks in terms of their relational and integrative capabilities, and really what you're trying to get at is that middle point where you're using and building networks through genuine co-production. Now, it's not easy to achieve, but I think what we can see by the kinds of initiatives that the UK government is putting in place, that we can begin to explore those if we have the innovation zones that will allow us to do these kinds of research projects that see different initiatives more or less successful in building the bridges and removing the barricades. So I'm sure there'll be questions afterwards, but thank you for listening.